Hello everyone and welcome to New Cancer Mentality. I'm David Farzam. Today we're extremely excited to be interviewing highly acclaimed doctor and researcher Dr. David J. Stewart. Dr. Stewart is a professor of medicine and head of the Division of Medical Oncology at the University of Ottawa in Ottawa, Canada. He was previously professor and deputy chair of the Department of Thoracic, Head and Neck Medical Oncology at the University of Texas, MD Anderson Cancer Center in Houston, Texas. He has more than 270 peer-reviewed publications in areas related to cancer clinical research and has edited the textbook Lung Cancer Prevention, Management, and Emerging Therapies, published in 2010. He has recently turned his attention to factors that he feels are impeding progress in cancer clinical research. He will be speaking to our audience today about these matters. So thanks again for being with us today, Dr. Stewart.
Happy to join you.
Excellent. So first off, could you define for our audience what is cancer?
Cancer is uncontrolled growth of tissues. Ordinarily, there are different genes that turn cells off when they're supposed to stop dividing and turn them on when they're supposed to divide. And that regulation is lost in cancer, so that there's uncontrolled growth as well as invasion into surrounding tissues and spread through the bloodstream and lymphatic channels to other parts of the body. So that's essentially what cancer is. It currently it causes about 30% of all deaths in Canada and somewhere about 27% of all deaths in the United States.
Getting into your research, could you describe to our audience what the role of the p-value is that's commonly used in statistical studies for randomized trials? How is it calculated? How is it used to make decisions about adopting new therapies, and why is it important in making good choices, but how can it also contribute to making bad ones at the same time?
The way it's calculated, it's about a mathematical formula or a series of them by statisticians. And essentially what it is, it's a probability that an association that you see or a superiority of one therapy over another is actually real rather than just being a chance observation just by chance. So if the p-value is 0.05, for example, then it's a 95% probability that the observation is real, that it's not just due to chance. If it's 0.01, then it's a 99% probability that it's real and not just due to chance. And by convention, it has to be less than 0.05 or greater than a 95% probability that things are real before you accept an observation as being probably real. And the way it's calculated is essentially what are taken into consideration are the size of the population that you're looking at, or the number of things you're looking at. The bigger, then the higher the probability that what you're seeing is real. The size of the difference between two groups, or the strength of the association. And again, the bigger the difference or the stronger the association, apparent association, then the higher the probability it's real. And also the degree of variability. So, for example, if you're comparing two groups, and one has an average value of 20 and the other has an average value of 40, and in the one the variation is from 18 to 22 and the other one it's 38 to 42, then that's a very low degree of variability and it's highly likely that it's real. Whereas if the variability in the 20 group was 1 to 80 and in the 40 group it was 10 to 99, then that's a far greater degree of variability, and hence a higher probability or possibility that the observation is just due to chance rather than it being real. And the reason it's important that we use it is that there are a lot of things that just by chance can look like they're important, but they're really not. It's just because of patient selection or because of other variabilities that make it look real when it's really not. So it's important in making choices. The places that it can get us into trouble, if you treat a very, very large number of patients on a study, like 6,000 patients on a study, which is common in cardiology studies, for example, you can find very, very small differences, like maybe a difference in survival of just 1%, and it's statistically significant. But the problem is it's not very clinically significant, but at the same time, the therapy can then be accepted and brought into standard practice based on the p-value being significant. But it's something that it just is not all that helpful. On the other hand, you can have a therapy that is very important, but if the p-value is 0.06, so 94% probability that it's real, it may get thrown out as useless. So you may discard therapies that are of value because of that. And it's particularly important if you have things that will only work in a subpopulation of patients and you do not first work out which subpopulation it is. For example, in lung cancer, there's something called an EGFR gene that can be mutated. And if it's mutated, that mutation is present in 10% of patients. And if it's mutated, then drugs like Tarceva and Aresa can be of extreme value, but they are very low value in people without the mutation. But if you just test it in all patients, then you will not find a statistically significant p-value, and so you'll throw it out, missing something that is of marked value in 10% of patients. But then if you increase the study so it's very, very large, so even though it's only 10% of patients, you may get a significant p-value, and then you'll start using it at everybody, despite the fact it only works in 10%, just because you have not recognized that, because you're relying on the p-value to make your decisions, rather than looking in more detail to figure out what's really going on.
Do they usually set a threshold then? So the threshold, I'm guessing, is a p-value less than 0.05%. So you have to be 95% confident, first of all, that the drug is working. And then do they set some kind of threshold usually, like 1 week, for example, if their survival is a couple months or something along those lines, then it's significant as well? Or is it just a p-value less than or equal to 0.05 and 0.05, and then the study is accounted for?
Hypothetically, it should be both, but in fact, the most important thing is the p-value of 0.05. And the way that it actually happens is that the study is set up to, so you hypothesize what size of a difference you want to find, but then you may find a smaller difference with statistically significant p-value, and the therapy that may then be approved. As an example, the drug Tarceva in pancreatic cancer, the survival gain is 11 days, and yet that's statistically significant. But many people would argue that that's not all that important. So that different countries, like the FDA and European regulators, Canadian regulators, will look at the size of the difference, but they may accept a very, very small difference just because of the fact that it does achieve a significant p-value. So therefore, the benefit is real. It's just that it's not of all that much value.
What do you think would be a better marker to use to see if a study is successful besides the p-value?
Well, I think that if you can predict which patients are going to benefit, and if you can do that fairly reliably, then rather than comparing two treatments, if you know that if a certain mutation is present, then there's a fairly high chance that the tumor will shrink, and if it's not present, then the cancer will not shrink, then I think that that's a fair game to accept it just based on that. And in fact, in the past, since 1970 until a few years ago, there had been 31 different drugs that the FDA had approved just based on response rates, so that you had a tumor that ordinarily does not respond to anything, and you see a bunch of patients have tumor shrinkage, and the drug was approved just based on that. So very small studies rather than the large phase 3 studies. And of the 31 that were approved, 30 remain in use today. There's only one that was thrown out, and it was thrown out based on a later faulty large randomized study where they did not recognize the importance of subgroups. So that drug was Gefitinib in non-small cell lung cancer, but it's unequivocally a drug of value in patients with an EGFR mutation, but it was thrown out. So that I think that we have to look far more at being able to predict which patients will benefit when they would not be likely to benefit to anything else, and we can then do studies that are much, much smaller, get them done much faster, and the drugs will potentially be of much greater value. Right now, there's something like 850 new anti-cancer agents that have the potential to go into clinical testing. We cannot possibly do large randomized studies in all of those. So some of them that are of value are going to get thrown out just because we can't do the studies the old way. And if we do the studies, then it's very, very expensive. It currently costs about $47,000 per patient on a phase 3 study. So that if you do a 2,000 patient study, that's going to cost you close to $100 million to do that study. And we just can't afford to do that anymore, because that's why medications are so expensive, is because of how expensive it is to do these studies.
So are you saying we need to be, so you're saying we need to be more specific than when we're choosing the patients? We need to find the right patient for the right study that will benefit them.
That's correct, and we have to be smarter about how we do that as well, because some investigators are now doing it just based on they're taking the large randomized studies and they're then trying to sort out if a patient has a certain biomarker, do they do better on the new study or not. The problem with that approach is that you can only test a very small number of biomarkers, and so you might hit it right or you might not, or you might by chance pick one that sort of is correlated with the one that's important, but is not a very good surrogate for it, and so that you don't end up with a lot of selectivity that way. On the other hand, if we look at the example of the again the EGFR mutation, again there were two different groups that looked at that, and both groups just used somewhere around 10 patients, 5 who had responses to the therapy with tumor shrinkage and 5 who did not, and just based on that they were able to. That's how they detected this. That's how they found this mutation. Both groups found the same mutation but at the same time, and essentially almost all the patients with the mutation responded. None of the patients without the mutation responded, and so that was a very potent way to discover it. In addition, there's another mutation called EML4 ALK translocation, and there's a new drug called crizotinib that was being tested. It inhibits another growth factor called MET, and in the phase 1 studies, in the initial phase 1 studies, it was noted that one patient had a very dramatic response. It turned out that patient had an EML4 ALK translocation, and it was not known beforehand that that was a potential target for crizotinib. But based on that, they then studied in a lot more patients, and the drug is very highly active in patients with EML4 ALK translocation. So we need to be smarter that way and try basing the selection of patients and the definition of who's going to respond based on response rather than looking at survival variables. If you look at survival, there's also what are called prognostic factors that can enter into it, because one patient with a tumor, well, it may live a lot longer than another based on prognostic factors, and it may have nothing to do with the drug that you used, but it's very difficult to sort that out unless you really know what you're looking for.
You speak in your article about an efficacy bar. Why is the low efficacy bar not served patients well?
Well, first of all, we'll look at the reason the low efficacy bar is there, and that's that back in the early 1980s, there were Congress started getting a bit tough on the NCI for not making a lot more progress. So the NCI said, okay, well, we may be throwing out a bunch of really good drugs just because we're treating very, very resistant patients, and maybe we have to treat less resistant patients. We'll find better drugs. The problem with that is that one then ends up with a whole bunch of drugs that work in exactly the same patients as the drugs that we already have, and we really need drugs that work where all other drugs do not work. So it encouraged us to aim low, and also again that those median survival changes of, for example, in pancreatic cancer, that change of 11 days with Tarceva, that's aiming low, and that really does not help us. The analogy we use is back in World War I with trench warfare. The objective of trench warfare was you sent your 100,000 men over the top into machine gun fire to try to capture a trench 200 yards away, and so you'd capture it. Then the next day the enemy would counterattack and capture it back again. And over 4 years of warfare, the front lines hardly changed at all. So there's almost no progress, despite more than 1 million lives being lost. And it was just in March of 1918 when German General Oskar von Hütter changed the rules. And he said to his troops, okay, forget about the trench. Go right past the trench. Go for the big guns in the headquarters 5 miles behind the trench. and leave the trenches to the mop-up crews. And with that strategy, Germany almost won World War I. That within 8 days they advanced 40 miles, by far the largest advance during World War I. And it was only with great difficulty that the Allies brought them to a halt outside the city of Amiens in France. And then the Allies counterattacked in August of 1918 using von Hütter's tactics against them, aiming high, and that was at the Battle of Amiens. And that brought they achieved far more than they'd ever achieved before, and that brought an end to the war within 100 days. So a war that is stretched on in stalemate for 4 years, suddenly it was brought to a rapid end just by aiming higher. And I think we have to do the same thing, because to aim low, you have to use up huge resources to aim low, because you need a much larger study to be able to show that you've achieved that small gain, and so that so it costs you a lot more money to do that, and you get a far smaller gain, and so the cost effectiveness when you translate it out into the clinic is much lower. You're paying a huge amount for not very much benefit.
Could you speak of the idea of using drugs not just against tumors based on histopathological type, but also using molecular and genetic profiling? Could you give our audience an example of when looking at the genetic and molecular profiles would be valuable?
Yes, in fact, there are a number of examples of that now, and we now know that it can take a common tumor can be caused by many different mutations. Like there may be 100 different mutations that can cause lung cancer, and a given new therapy may only work against the patients with one specific mutation. So if you use that drug against patients just based on histopathology, then you may throw out the drug as being next to worthless. But in the 1% of patients or 10% of patients that have the right mutation, it may be the best drug that ever came along. And so we've probably been throwing out a large number of agents that are highly effective, but in very small subpopulations. And because we kept on looking for the drug that would work in everybody with the disease, and that's just not going to happen with a common tumor where many different mutations can cause it. Examples, again, coming back to EGFR mutation, where it's present in about 10% of patients, and the drugs Iressa and Tarceva are of marked benefit. EML4 ALK translocation, present in about 4% of patients with non-small cell lung cancer, where the drug crizotinib is highly effective. HER2 new positive breast cancer, where Herceptin is very effective. Estrogen receptor positive breast cancer, where the old drug tamoxifen, that was the first example of targeted therapy using tamoxifen and related hormonal therapies in patients with estrogen receptor positive breast cancer. There's the BRAF V600E mutation in melanoma. If that's present, then BRAF inhibitors are very, very effective. There's gastrointestinal stromal tumors that have c-KIT mutation. That was a tumor that was very resistant to standard chemotherapy, but if the c-KIT mutation is present, then the drug Gleevec or imatinib is highly effective. So we're seeing more and more examples of this coming along. So it tells us that this is a valid way to go about doing things.
Could you describe in more detail exactly how genetic profiling would be done, and could this be done in the clinic in a pretty short time period?
Yeah, for example, like right now, if we want to test a patient to see if they've got an EGFR mutation, that takes us. We can do that in 1 to 2 weeks. So it takes about the same length of time as it does to check for estrogen receptor status in breast cancer. So it can actually be done fairly rapidly. And so essentially what we do is we just, when we get the pathology report, we request the pathologist then take the next step to do the molecular profiling. Down the road, in fact, we should be doing very broad molecular profiling because, again, if there are 100 different mutations that can cause lung cancer, then we should be setting up systems to look for all those mutations. And that actually may not be any more expensive, or hardly any more expensive than just looking for one, because the expensive part is extracting the DNA, the genetic material from the tumor, and then setting up the assays originally. But there is now technology that can look at the same time for about 100 different mutations. And in the very near future, we should be able to actually do just about whole genome sequencing on the tumor. There's new technology now. Just a few years ago, it would have cost $3 million to do whole genome sequencing on a patient's tumor. I just heard a couple of weeks ago that there's now technology available that's brought that down to $1,000 a patient. And then the tough part is going to be the interpretation, how you interpret that. But there are going to be algorithms put in place over the next few years that will permit us to do that. So that by 10 years from now, the hope is that we will not be treating any patient without having detailed genetic knowledge on their tumor, and maybe also on their own normal background genetics, which can affect things as well.
And this is really important because every cancer cell is different and it's unique in every single patient. So by being able to do this, we can select the right patient for the right type of drug, which is very important.
That's correct. Now, there are groupings so that all patients with EGFR mutations, for example, behave more or less the same with some variability. And so that as part of the research in the future will be to see what else we have to do to individuals based on that variability. But things are going to be much more specific in the future, just because patients will do better, and also it'll be huge savings to the healthcare system. Like right now, if I take a chemotherapy regimen and use it on all patients with lung cancer, but only 10% have the target required for that therapy to work, and I have no way of sorting that out, then 90% of patients are getting expensive and toxic therapy that's just not going to help them. So that this is an important move forward.
Would it, and I think you've touched on this, but would it be economically feasible to develop drugs based on small molecularly distinct subpopulations of cancer patients?
Yes, the answer is it would be, and people always all one has to do is look at the example of Gleevec and chronic myelogenous leukemia. Chronic myelogenous leukemia is an uncommon malignancy, and the frequency is the same as some of the less common subtypes of lung cancer. And yet Novartis developed the drug Gleevec and have made a fortune on it, so that yes, you can do it in small subpopulations. Now, I think the other part of it is that we also have to make the whole drug development process much more efficient, much less expensive, and there are lots of ways we can do that, so that if we can develop a drug in 5 years instead of 15 years, and if we can spend just $10 million or $50 million to develop it rather than spending $2 billion, then it becomes much more feasible to do this, and that the methodologies and the technologies are there to do that.
Why do you feel that smaller phase 3 clinical trials should be implemented?
Just because then you have to aim high. If you launch a very large phase 3 study, by definition you are aiming very, very low, and so I think that's just the wrong strategy. Also, if you do the small one, if you find a gain, then it's going to be a worthwhile gain, because it will only find the worthwhile gains. And the study will be much cheaper, it'll be much faster, and so that everybody benefits from doing smaller, much smaller studies.
Could you speak about blood-based biomarkers and the role you see these biomarkers playing in the near future?
Yeah, there could be a number of them. Right now, there are not a lot there of benefit. There are a few examples of some, like in testicular cancer, beta-HCG and alpha-fetoprotein are of value. In colorectal cancer, CEA is of some value, but they're just to look at tumor burden rather than looking at which patient should be treated in a certain way. But just starting with your normal lymphocytes in your bloodstream, from that we can actually look at your normal genes, not the ones from the tumor, but your normal genes. But the tumor actually inherits those genes and then mutates some of them. But a lot of what goes on in the tumor is determined by actually your normal genes and how it's modified by mutations. And so that, for example, if we treat you with a certain chemotherapy drug, then the probability of response is also affected by your normal genes that the tumor has inherited. And so that can help. So just knowing your normal genotype can be important. That's called pharmacogenetics. So that's one thing. The other thing is looking for circulating tumor cells. We know that patients with cancer, there can be millions of tumor cells circulating in the bloodstream. Many of them die, so that, and that's why some people are cured by surgery and radiation, is because in some people all those tumor cells die and don't land and plant in other places. But if we can harvest those tumor cells that are circulating, then that may save us having to do a biopsy on the tumor, and that can be value. The other thing is that tumor cells are sick cells, and they die, and they dump their DNA out into the bloodstream. So if you actually just look at free DNA floating through the bloodstream and analyze it, you're actually analyzing the tumor's DNA, and so that you can potentially get an idea of what's going on in the tumor without having to do a biopsy. So there's a lot of potential there, but so far not fully realized, but there is potential.
You stated in your article that you feel tumor and blood samples should be collected and broadly profiled as early as possible after diagnosis. The process then becomes finding the right patient for the right study rather than the right study for the right patient. Is it always possible to easily option a biopsy from a cancer patient upon diagnosis?
We try to avoid using the terms always and never in medicine, just because there are always exceptions to everything. But for example, we currently almost rarely give treatment without having a biopsy first. So we are able to get that biopsy just to find out what kind of cancer it is. In breast cancer, it's very uncommon for people to go ahead and give treatment without knowing what the estrogen receptor status is. So if there's not enough tumor the first time around, you go ahead and do another biopsy. So that if we make it a priority, then it will happen. It can happen. As an example, when I was down at MD Anderson Hospital, we launched a large study called BATTLE that required fresh biopsies on patients with previously treated advanced lung cancer. And many people said we could not possibly do that study, that patients would not agree to the biopsies or they'd be too dangerous. But we rapidly accrued 300 patients in that study, and patients were very willing to do it. It was very safe, and we proved that you could do these biopsies and actually profile them very rapidly to get molecular information on the patients, and that could help guide therapy. So yes, if we make it a priority, then it will be something that can be done. There could be a few exceptions, like it'll be more difficult to get tumors from the brain, just because if you do a biopsy in the brain and bleeding starts, that can be more dangerous. So that there will be some situations that a certain proportion of patients will be that it'll be difficult or dangerous to do it in, but the majority of patients will be possible.
Could you give your opinion? We recently had, or in the past, we had Dr. Arnold Glaser come and speak about the idea of looking in normal cells and looking for cells that have genes that have markers that could basically be cancerous, in the sense that these markers are showing that these cells can proliferate and they can invade other parts of the body tissues. Could you speak about this idea a little bit, and do you think we could look at the normal cellular machinery and see if that could lead on to cancerous problems in the future?
Yeah. Sure. In fact, actually, there are a few different aspects of that. One is that, for example, patients that have BRCA1 and BRCA2 mutations, we know that they're at increased risk of getting ovarian and breast cancer. And so just by knowing that that mutation is present in all normal cells in that patient tells us that they're at high risk. And there are other examples of inherited cancer syndromes like that as well that can tell us that people are at risk. And they even give us some indication of which cancers the patient is most likely to develop. For example, another kind of mutation that a couple other kinds of mutations will lead to an increased risk of colon cancer, just as an example. Then if you're looking in people that do not have those known mutations, but you're looking for damaged cells, again, you can find them. For example, if you look in the do scrapes of the mouths of patients, you may find something called loss of heterozygosity. And if you find that, then you know that those patients are at increased risk of developing cancer, because a number of mutations are already present that are precancerous mutations. So yes, there is the potential that will happen in the future.
Could you also give your thoughts on this idea that most adult solid tumors have aneuploidy, or an abnormal number of chromosomes? Do you think at some point we can target this abnormal number?
In fact, actually, that's exactly why chemotherapy works, is because the DNA is damaged. Like they're useful chemotherapy drugs. They're useful because the tumor cells are more sensitive than normal cells. And part of the reason the tumor cells are more sensitive is because they have that abnormal DNA and other things like that. And there are some examples of some chemotherapy agents in some tumors that if the drug is highly aneuploid, then it's much more sensitive to chemotherapy than if it's near diploid, that is near normal. On the other hand, there are other types of chemotherapy drugs and other tumors where the near diploid cells are the more sensitive ones. So there is variability from that perspective, but part of the intrinsic sensitivity of tumors to chemotherapy, one of the reasons that we actually get some benefit from standard chemotherapy drugs and radiation, is because of the highly abnormal genetics in the cancer.
And finally, on the topic of using angiogenesis and stopping blood flow to cancerous regions, what are your thoughts on that idea?
It's been demonstrated to be of some value, and we don't yet know for sure whether it'll be a double-edged sword, so that if you decrease blood flow to the tumor, you may also decrease drug delivery to the tumor as well. You may decrease oxygen flow so that radiation may be less effective, but there's also some work suggesting that the blood vessels become more normal, so you may actually improve drug delivery. We do know that there are several different malignancies where survival is prolonged if you use things like bevacizumab or Avastin, which interferes with blood flow. But we are not yet doing a very good job of predicting which patients are most likely to benefit from those therapies, or which patients, on the other hand, may be harmed by those therapies. And we need to do much more to define that. But the principle has been confirmed that these types of therapies can be of some value.
Why do you feel more effort should be placed to target patients with highly resistant tumors in initial phase 2 trials rather than lightly treated patients?
Because, again, I mentioned before that the NCI back in the early 1980s started to target lightly pretreated tumors in the hope that they would not throw out good drugs. But what they ended up with was a bunch of drugs that just worked in the same patient, same tumor cell populations as the older drugs. And on the other hand, if you use a drug against a tumor that's highly resistant, not responding to anything else, and that tumor responds, then you have found a good drug. That drug is something that will work where other things have not worked. That, I think, is a key to moving forward. So stop aiming low, aim for things that can do the job where other things cannot do it. And you find that by identifying a drug that can cause marked tumor shrinkage where nothing else can work. And for example, again, the drugs Tarceva and Iressa in patients with EGFR mutations, they were able to cause tumor shrinkage where standard chemotherapy could not do it in highly resistant tumors. So this is a hallmark of a drug that can be effective where other things have not worked.
Why do you feel that cancer can't be a chronic disease that patients live with?
When people talk about turning cancer into a chronic disease, they're talking maybe of a few months or a year or 2 years, because the problem then is that the cancers will have mutations, so they will mutate to a more resistant form, so that it's much more difficult to keep it just chronically suppressed by something because of the emergence of resistant clones. So that it's a nice theory, but the problem is actually doing it. The other thing is that if you can cure a cancer, patients would much rather be cured than just have a chronic disease. If you talk to anybody with diabetes and say, if somebody could cure you, would you want that rather than just keeping your diabetes chronic? They say, of course, I'd prefer to be cured because then it can stop all this treatment. And we do know that we've got the potential to cure cancers because we're already curing some of them. We're curing metastatic testicular cancer in up to 75 or 80% of patients. We can cure some leukemias, some lymphomas, so that if we've got the potential to do that, then why not aim for that? Again, aim high rather than aiming low, and because we know that there's at least a potential there to do it.
Why do you feel progression-free survival should be used when randomized trials are conducted in patients with metastatic disease rather than looking at overall survival?
Because there are many different ways that you can affect overall survival, like just by concurrent agents that you give. Also, there's different prognostic factors and things like that come into play. The other problem is that, say if you have a drug that increases progression-free survival from 3 months to a year, but then with subsequent therapies, all patients live for an additional 2 years beyond that. The way that the statistics are set up with what are called hazard ratios, first of all, with the progression-free survival, your hazard ratio is about 0.25 or 0.3. But then when you add on for overall survival, the additional survival caused by other things afterwards, then suddenly your hazard ratio drops down to about 0.8 or thereabouts from 0.2 or 0.3. And so you're much more likely to throw the drug out as being worthless, even though you still have that, you've maintained that 9-month improvement in survival, but you just have a much harder time to show it. The other problem is that with crossover therapy, that if you're on a new drug, and at the time of progression, the people that were on the placebo or the standard therapy get crossed over to the new drug, then it will look like the drug's not doing anything because the survival is the same, because the patient who got crossed over also got the full benefit from it. And so you'll throw it out as worthless, when in fact the true message is that works whether you give it front line or second line. And so that people then try to get around that by setting up randomized studies where crossover is forbidden. And one example of that in the New York Times, that was discussed in the New York Times, was the BRAF inhibitor in malignant melanoma, where patients going on the study were forbidden to cross over. So you had a drug that could cause marked tumor regression in people with a mutation, and we already knew that it could give marked symptomatic relief, and most people would have predicted that it was going to give survival benefit, and yet patients were told that if you want to get access to this drug, you have to go on the study, and then it's a lottery whether you get it or not, and you're not permitted to try to get it from anywhere else if you're chosen not to get it. So a lot of people had a lot of problems with the ethics of that. And in addition, because there were other drugs that hit the same target, then if the patients went on the standard treatment, did not get it, any smart patient, any logical patient would then go and try to get some other drug company's drug that hit the same target, because they would just go to a different oncologist. And so if they got it and then they did fine, then your study of the original study becomes negative because of the way it was set up. You get a false negative. So that those are the reasons. The downside of progression-free survival is that it is somewhat difficult to measure accurately and to define it, and so that you can have problems because of that. Even more important may be looking at response, where you actually look at the tumor diameter, how much does it decrease with treatment. Again, that's a very good surrogate for an effective drug, and it's very good at trying to pick out which markers predict benefit from the therapy.
Excellent. Could you speak about why you disagree with having a high regulatory bar when clinical trials are performed? Why do you feel protocols have come to be regarded as legally binding documents rather than guides?
First of all, regulation is absolutely essential. I mean, there's all sorts of bad things that have happened in the past and would happen in the future without regulation. So regulations are very, very, very important, but they have to be smarter regulation. The problem now with the way that the regulatory bar is set is it now takes far too long to get a drug approved, and many of the regulations that are in force have never been shown to really accomplish anything. So they slow things down. Back in the 1960s, it took an average of 8 years to take a drug from discovery to approval. Now it takes 12 to 15 years, and a lot of people who could have benefited from the drug die during that time period. In addition, it's much, much, much more expensive now to get the drug approved. And if you're spending a huge amount to get one drug approved, that means that money is not available to test a whole bunch of other drugs that also might be of value. So you slow down the process that way as well. And so I think that's bad. So we have to be much smarter about how we do things. We did a calculation of how much the benefit of the new regulations, of more stringent regulations. And essentially, in phase 1 studies, for example, it cut the toxic death rate from 0.8% to 0.5% over a period of 10 or 15 years. So that's a gain of 0.3%. And we know that it takes about 5,000 patients on trials to take a drug from discovery to marketing. So, and if the average life expectancy of a patient with advanced cancer is a year, then that would say that we save 15 life years or 16 life years over the course of getting the drug approved. And so that's good, except that if it delays the drug by about 5 years, then we calculated out that you may lose 2 million life years worldwide during that time period. So you save 15, you lose 2 million. So that's not a very good balance. The other thing is that we calculated out the cost per life year gained by looking at the cost of regulations, just complying with regulations, as $2.7 million per life year gained. Now, if I went to any payer and said that I had a new drug that I wanted to treat a patient with, and it was $2.7 million per life year gain, they'd tell me that no way were they going to pay for that. The standard bar is that you pay $50,000 maybe, or maybe $100,000 per life year gain, for example, for dialysis, and that's what the bar is. So $2.7 million is way out of line, and it suggests to me that the regulators may be going about saving lives in the wrong way, that they really need to do things differently. And the analogy we use in the paper is the Autobahn in Germany that has unlimited speed limits in many parts of it, and yet it has one of the lowest traffic fatality rates in Europe. And they did that by smart regulation, not by a lot of regulation, not by a little bit of regulation, but by smart regulation. That's what we need in cancer clinical research. We need smart regulation that permits very rapid speed, but with a reasonable degree of safety. It's far different if you're testing a drug for acne or for high blood pressure, where you need to have very stringent safety measures. But in lethal diseases like cancer, we need to be able to move forward much faster with far less cost than is currently the case. And so it used to be protocols used to be fairly flexible, so that if the protocol was not making sense, we could tweak it. You could change it a bit so that it made sense, and so you could keep moving onwards. Now you have to stop if it needs a modification, stop and submit an amendment, and then it may take you 6 weeks or 6 months or longer to get that amendment approved, and everything grinds to a halt during that time period. That's just not rational. People need to be able to move forward rapidly. The reason that they've become far more rigid, people say it's for more safety, but in fact it's not. The actual real reason for that is that it's been mandated that regulators must pay far more attention, and they must control things. If the regulators must control things, then they need a way to do it. And so you get auditors in, and the auditors are not trained physicians, they're not trained oncologists. They're people that can read a protocol, then they can read a chart and say, so if you say that the patient needs a serum creatinine less than a certain level, say 1.0, to be able to go on treatment, they can look at that and they can check it off. If the creatinine is 1.1 instead, and you say that patient should be able to go on, they said, no, you can't. This is not what the protocol says. So things become much more rigid because you have people that cannot make judgments that are interpreting things very, very rigidly. Again, the analogy we use is that if you're out on the highway and the speed limit is 60 miles an hour, and everybody says it's perfectly safe to go 60 miles an hour, so that's fine. You go 61 miles an hour, and suddenly you're thrown in jail for 10 years for reckless endangerment of everybody's lives around you, that this is a horrendous safety violation if you go 61 miles an hour instead of 60 miles an hour. These things just do not make medical or biological or safety sense. But this is the way it's set up so that people that are not qualified to make judgments can actually audit and regulate these things. This is just not a good move from my perspective, and it again makes things far too expensive and slows things down far too much with very little potential gain and no demonstrated gain. There is no data that this makes a difference. And also just from the perspective of getting drugs approved, David Dilts from the University of Oregon did a study of just the activation of clinical trials in so-called cooperative groups, cooperative oncology groups, and he showed that it took a minimum of 2 years, or an average of 2 years, from the time that the idea was conceived until the study was activated, with 350 to 450 distinct steps required to get the study activated. There's no call for that. Those things are just not necessary, and in the study he did, at least half the steps had no demonstrated value or no potential value, and yet they're massively slowing things down. So we can do it better. We need to do it better.
Who's currently in charge of making these changes, and how can we contact them?
Okay, one of the problems in the United States, there's a whole bunch of well-meaning people that are trying to do the right thing, but there's regulatory gridlock. So that the FDA might want to make some changes, for example, but then the OHRP or the Officer of the Inspector General or NCI or CMS or somebody else will say, no, you can't make that change. We've got regulations that prevent you from doing that. And then one of those other groups will want to make a change. The NCI will want to do something differently, but then FDA or OHRP or somebody else will tell them they can't do that. And so there's gridlock there that just prevents people from moving forward to make the changes that are needed. The thing that, and in Europe, again, they've got also a very complex regulatory system there as well, so that makes it very, very difficult to move forward. As far as who to contact, in fact, it's Congress ultimately that has to do this because they're the ones that have to enable it and permit it within the United States. And so advocacy groups can also do it. The value of advocacy groups was shown in the AIDS epidemic. They got the rules to be changed, and things that proved that things can happen quickly, and they did with huge strides in a very short period of time. That showed the potential value of that type of approach. One issue that we've got in cancer right now is that the advocates tend to be broken down by tumor type, and they spend far more time advocating to try to get more resources for research in their individual tumor type. And if it happens to be made up of many survivors, then they're worried about the toxicity that they've experienced, which is valid concern. But then the focus goes on toxicity, not on all the other patients that did not survive to become advocates and have died because of their cancer, and they died because progress has not been made rapidly enough. But we need to just change the speed, rapidity of progress has to become the driving force. Rather than the regulations. In fact, one of the real thing that's actually happened worldwide is that compliance with regulation has now usurped progress as actually the primary, most important outcome of clinical research. If you do a study and you're not fully compliant to the extent that the FDA wants, and say that your study shows a doubling of survival of lung cancer patients from 1 year with metastatic disease from 1 year to 2 years. But if you're not compliant, the data are essentially thrown out. You're not allowed to publish it. You're not allowed to present it. You're not allowed to use it to choose therapies for patients or to get to the drug approved. the data is essentially thrown out. On the other hand, if you do a study that shows that the survival increases 6 weeks and you're fully compliant, then that becomes a new standard of care. You get to publish in the most prestigious journals, to present in the most prestigious venues, and so that it's compliance that is really usurped progress as the de facto primary, most important outcome research. And that's what we've got to change. We've got to change it back to progress being the most important outcome, not compliance with regulation. Regulations, as I said, highly essential, very important, but we need to find a way to do that better.